Hello, and thank you for your interest in this talk. I'm Dr. Mark Schinsky. I am the Director of Complex Hip and Knee Replacement at the American Hip Institute and the American Hip Institute Research Foundation. I'm going to spend the next few minutes discussing total hip arthroplasty, the latest and greatest from minimally invasive surgery to robotics. Just in review, total hip arthroplasty has been called the operation of the century. This is a review article from The Lancet back in 2007, describing it as that. And why is that? Well, total hip arthroplasty is one of the most successful and cost-effective procedures. But how do we determine success in any operation? We use something called the quality adjusted life years. This has been the gold standard for the last 30 years or more to determine the effectiveness of different medical interventions on increasing, improving quality of life or to the duration of life. It's a scale from 0 to 1. 1 is a full year of perfect health. And total hip arthroplasty has been highly rated and giving patients exceptional increase in their quality adjusted life years, and has been one of the, again, most cost-effective operations in all of medicine. It is also one of the most frequently performed operations. This is back from 2014 of in-hospital operating room procedures. Of course, you can see C-section and circumcision are number 1 and 2, but those are essentially always done in hospitals, followed rapidly by knee replacement and hip arthroplasty. But from 2014 to more recently, these numbers are shifting. Hip arthroplasty has been moving more and more to the outpatient realm from being truly just an inpatient surgical procedure. The demand for hip and knee arthroplasty is also significantly increasing. You can see the projections here to 2028. And most of that increase in demand will be moving in the outpatient or surgery center realm as we do more and more outpatient total joint replacements. And there are several reasons for that, and those are what we'll be discussing throughout the rest of the talk. Hip replacement has seen some fairly significant improvement and will continue to see some dramatic improvements over the next upcoming several years. Over the last many years, the direct anterior approach has been one which I think has significantly increased the ability for patients to recover and reduce potential complications. The direct anterior approach is actually nothing new. It's been around for many decades. We are in essentially our third iteration of this. It was tried several episodes prior. Those did not work quite as well. However, I think our technology has caught up with our improved implants and our improved techniques and instruments to allow this to be what I think is going to be the gold standard approach for hip arthroplasty moving forward. It is a true intermuscular and internervous plane for performing hip arthroplasty. We are all searching for what we describe as the personalized hip joint replacement. This includes functional biomechanics from restoring the native hip center, restoring length and offset, increasing the appropriate stress transfers to minimize bone problematic remodeling and osteopenia, improving hip range of motion and stability with a stable joint, which is impingement-free. We're certainly looking for what's described as a forgotten joint, where essentially the patients forget that they've even had their hip replaced. We're increasing and improving our wear resistance so that these implants do not wear out, and hopefully we'll have lifetime implant survivorship. And then, of course, rapid and complication-free recovery. As you've likely heard in other talks about femoral acetabular impingement in a native hip, you can also have impingement around a hip replacement. There are a couple forms of this. The implant can impinge on the implant itself. On the left, you can see where the femoral neck is impinging on the acetabular shell, or you can get bony impingement, as described here on the right, around hip arthroplasties. We can help to minimize that with our use of large diameter femoral heads. This has been a relatively recent change. Increasing the size of the femoral head can allow us to increase the hip range of motion, decrease impingement, and it can also increase what's described as the jump distance, which can help decrease dislocation and improve stability around the hip joint. This has only been possible more recently with improved implants allowing us to have thinner metal shells and improved wear mechanics of our plastics to decrease the thickness that is required, which then allows us to have larger femoral heads. We're also moving more and more into 3D printed and additive manufactured implants. You can see primary implants for the acetabular shell here on the left, and a more complex pelvic reconstructed additive manufactured implant here on the right. That's used more in the revision setting. Additive manufacturing and 3D printing allows us to do several things with antibiotic therapy. There's several different strategies. Some of the alloys that we're using are actually antimicrobial in and of themselves, or we can fuse antibiotics through different measures and means to the different metals, which has been only possible in recent years through some of the advanced technologies in metallurgy and 3D printing. Another example of 3D printed here, you can see a large acetabular defect with loosening of the acetabular shell and this X-ray and CT scan here on the left. The patient is then modeled and the defects are all mapped and new implants are created digitally. They're then created in plastic to ensure appropriate position and function and what the surgeon desires. And finally, they're additive manufactured and 3D printed and then implanted into the patient, and you can see a successful outcome here. We are also having a better understanding of the spinal pelvic parameters. Of course, as we all know that the pelvis shifts as we go from sit to stand or stand to sit. This can be certainly changed in what's described as the spine hip syndrome, or having a stiff spine where the pelvis does not rotate as it normally would. This can lead to increase in impingement and instability around the hip. And as we understand these relationships and these parameters better, we can more accurately and precisely place our implants in positions leading to decrease in impingement and hopefully therefore increase in stability for some of these patients that do have the stiff spine hip syndrome. We're using more and more surgical navigation. This involves placement of some pins and a camera with some trackers and arrays so that we can help guide our procedure during surgery. So you can see pins placed in the pelvis, camera mounted to those pins, and then a tracker on our instruments to help accurately place, in this case, our acetabular shell. But it can also be used with some trackers on the femur to help with length and offset changes during hip arthroplasty procedures. We're using more and more augmented reality. This is where information is displayed essentially virtually through these goggles that the patient, or so that the surgeon uses during the operation itself, and projected and overlaid on the surgical field to help navigate and place the components in the appropriate position. We are, of course, using robotic-assisted surgery. This is what we use for essentially the majority, if not all, of our hip arthroplasties performed here at the American Hip Institute. And I'll walk you through that through the next several slides. This involves creating a preoperative patient obtaining a preoperative CT scan, and a 3D dimensional model is then created. And we use this model to plan the surgery even prior to entering the operating room. So we know where in space we want to place these implants, and we can appropriately place them on the model and put them in the appropriate inclination and version, and then also help determine any length and offset changes that we desire. This is what it looks like in the surgical field. So again, pins are placed into the pelvis. Attached to those are the arrays. The robot has its own set of arrays. During surgery, the pelvis is mapped, and then the robot in the computer uses this mapping to know where in space the pelvis is in relation to the arrays. We can also help use it to make the appropriate and planned femoral neck cut for appropriate femoral length and offset. Then with the use of robotic assistance, and once the robot knows where the pelvis is in space, we can use the robotic arm to assist us to remount the acetabular shell in the appropriate orientation, and finally impact the cup in the appropriate inclination and version compared to our preoperative plan in the desired location. Finally, we place the femoral component and reduce the hip, and we can determine that we have restored this patient to our desired preoperative plan, restoring length offset with the appropriate cup placement. For surgical procedures to be effective and successful, we need an entire perioperative pathway. This starts well before the operating room itself with appropriate patient selection. It helps us to determine which patients are appropriate candidates for surgery and which are not. We then optimize patients preoperatively. There are modifiable risk factors that we know can affect patients' complication rate and recovery, things such as smoking, diabetes, et cetera, that can be modifiable and have the patient have the best outcome possible. I discussed several things that we use during the operative day, including the use of technology, antibiotics, tranexamic acid, which helps reduce blood loss, antibiotic prophylaxis, et cetera. And then finally, postoperatively, through the use of multimodal pain control, cryotherapy, early mobilization and physical therapy, and DVT prophylaxis can help lead to a successful operation and recovery for these patients. Thank you very much for your time and attention today. I am always happy to discuss this further. If you have any comments or questions, please feel free to reach out. I'd be happy to discuss them further. Thank you very much and enjoy the rest of your day.